She sat in the parking lot for 20 minutes after the appointment. Not because she was upset, because she could not answer the text her sister had just sent her. How'd it go? What did the doctor say? And she genuinely did not know. She'd been in the room, she had heard the words, she had nodded, she had even said, okay, a couple of times in that tone that means you're tracking, you're present, you're following along. And she walked out with a prescription she didn't fully understand, a follow-up appointment she was not sure was actually necessary, and zero clarity about whether her mother was getting better or getting worse. So she sat in the parking lot, phone in hand, and typed back the only honest thing she could. I think I went okay. I'll call you later. And look, that's not a failure of attention. This is not a failure of intelligence. That is what happens when no one has ever taught you how to be in a doctor's office as an advocate for someone you love. Today, that changes. 3 questions. That's all it takes. Welcome to the Aging Parent Playbook. I am Dr. Barbara Sparacino, triple board certified psychiatrist, geriatric psychiatry specialist, and the founder of the Aging Parent Coach. I am also a daughter, and everything I teach here, I've either lived, studied, or sat with patients and families through for the past 2 decades. This podcast exists because adult children of aging parents deserve more than generic advice. You deserve clinical precision delivered in a voice that feels like a friend who happens to know exactly what she's talking about. Last month, we spent time in Legally Ready pillar, power of attorney, capacity, the documents. Today, we pivot into pillar 3, care clarity. This is where we talk about navigating the medical system on behalf of your parent and making sure the care they receive matches the care they actually need. I want to be honest with you before we start. I am not here to make you distrust doctors. I am one. I trust physicians. Most of the physicians your parent sees are genuinely trying to do the right thing by them. What I am here to tell you is this. The families who get more from the medical system are not the loudest ones, and they are not the ones with medical degrees. They are the ones who ask a small number of excellent questions and ask them every single time. Today, I'm giving you 3 of those questions, the exact words, and I'm going to tell you what each one does and why it works. Let's get into it. So, why does a medical visit fail adult children? Before I give you the questions, you need to understand what you're walking into. Not to excuse it, to work it, right? A typical follow-up appointment for an older adult is scheduled for 15 to 20 minutes. And after the rooming, the vitals, and the computer, the physician has maybe 12 minutes of actual conversation. In those 12 minutes, there is a problem list with 6 to 8 active items. There are medications to reconcile. There are screenings the system requires. There is documentation that has to happen, often while your parent is still talking. So the visit defaults to triage. The most acute thing gets the time. Everything else gets maintained. And the deeper questions, the trajectory questions, the what matters most questions, these get crowded out. Not because the doctor does not care, because nobody put them in the container, right? Here is the insight that changes everything. You are allowed to put things in the container. You are not just there to receive information. You are there to advocate. And advocacy, done well, is not combat. It's steering. The 3 questions I'm about to give you are the steering wheel. And your parent, who may be hard of hearing, who may be differential to authority in the way many of their generation often genuinely are, who may be in the early stages of cognitive changes that no one has formally named yet, is not going to flag when they do not understand something. Their whole life has trained them not to do that in a doctor's office. So the information gets delivered and it does not get received. That gap between delivered and received is exactly where bad things happen. And that is what we are closing today. So before you walk in, the one-page brief. One piece of preparation first, because the 3 questions land best when the first half of the visit has not been eaten by reconstruction. Reconstruction is what happens when the doctor spends 8 of the 12 minutes assembling the story. When did the dizziness start? Which pharmacy fills the metropolol? What was the dose again? So bring a one-page brief, 1 page, not a binder. 4 things on it. First, the current medication list. Everything, including supplements and anything over the counter, please. Because the herbal sleep aid and the Benadryl matter more than many families realize, especially in older adults. Second, what has changed since the last visit? In 1 or 2 lines with rough dates. More tired since mid-May. 2 stumbles, no falls. Eating less at dinner. Specific, dated, brief. Third, your top concern for this visit. Just 1. If you bring a list of 10 things, you will address none of them well. Pick the one. If you left without addressing it, would feel like a failure. And fourth, 1 sentence about your parents' current goals and priorities. She wants to stay in her home as long as possible. He is most worried about his mobility. That sentence reorients the whole visit, right? A good physician will read it and will shape every recommendation they make. Because medicine is supposed to serve what the patient values. And far too often, no one has said out loud what the patient actually values. Hand the page to the doctor at the start. Say, 1 sentence, I put together a quick summary to help us use the time well. Most doctors will be genuinely grateful. And you have just been mentally refiled, fairly or not, as a family whose questions deserve real answers. Now you are ready to ask them. So, what are the 3 questions? Question 1. What are we watching for? After any diagnosis, after any prescription change, any new treatment recommendation, you ask, what are we watching for? What this question does is force the doctor to give you the monitoring plan, not just a snapshot of what's happening right now in this moment, but the forward picture, right? What would tell us things are getting worse? What would tell us things are getting better? And what would prompt us to call or come in before the next scheduled appointment? Here's why this matters so much for older adults specifically. Medication side effects in aging bodies do not always look the way you expect. A new blood pressure medication might not cause the dizziness listed on the package insert. It might cause confusion. It might cause falls because blood pressure drops when your parent stands up. It might cause fatigue so significant it looks like depression. It might cause a subtle change in personality that you notice but can't quite name. If you do not know what to watch for, you will not recognize what you are looking at when you see it, right? You will call it aging. You will call it a bad week. You will wait another 3 months until the next appointment. And by then, the thing that was, manageable has become something more. Here is the exact phrasing I want you to use. After the doctor finishes explaining anything, you say, before we move on, I want to make sure I know what to watch for. Between now and our next appointment, what would concern you? And what would tell you things are going in the right direction? Then write it down, not on your phone, on paper in front of the doctor. Because when someone picks up a pen, it signals that what is being said is worth recording. It slows the pace of the conversation just enough to produce a more complete answer. And if the doctor says, just take the medication, you will be fine, you gently come back. I understand, but if I notice something, what specifically should prompt me to call? That is not being difficult. That is being thorough. And any good doctor will welcome it. The second question is one I learned from the other side of the desk. And it is the one I think about most. What is most important to my mother right now? Or even better, ask your parent first in front of the doctor. Mom, what is most important to you right now? And then turn to the doctor and say, given that, what should we be focusing on? I call this reordering the question. Here is what it does. Every problem list in a medical chart has an order, and that order was set by the system. Lab values, billing codes, whatever got flagged at the last visit. The reordering question takes that list and resorts it by the only criterion that actually matters, which is your parent's life, right? Maybe what is most to your mother is staying in her house. Maybe it is being clear-headed enough to really enjoy her time with her grandchildren, even if that means accepting a little more physical discomfort. Maybe it is not being dizzy because the dizziness is the reason she stopped going to church, and church is where her whole community lives. When that answer is on the table, the medical decisions reorganize around it. A blood pressure target might soften. A medication causing cognitive fog might get reconsidered. A referral that did not seem urgent suddenly becomes the more important one. And here's what the question does to the doctor. It makes us stop and look at the patient instead of the chart. I will be honest with you, there are visits where I have not asked this question clearly enough myself, and a family member asking it gives me back the framework I am supposed to be using. The families who ask it are not challenging me, they are partnering with me. And every good physician feels the difference. Watch what happens to your parent when this question gets asked. The quietest person in the room suddenly has the floor. I have watched parents sit up straighter because someone finally asked what they wanted instead of deciding what they needed. Keep a follow-up version in your pocket for when the answer is already on the table. Given that staying home is what matters most to her, is there anything in today's plan that works against that? That question forces the plan to be measured around the goal, right? Sometimes the answer is no, and you leave reassured. Sometimes the answer is, well, actually, this medication does increase the fall risk. And now you are having the conversation that would have otherwise have happened in the emergency room, right? Instead of emergency room 6 months from now. So now question 3. And this is the one that almost no one asks, right? In my clinical opinion, it is the most important one on the list. What happens if we do nothing? Medical recommendations exist on a spectrum of urgency that is almost never communicated clearly to patients and families. At one end, if you do not act on this in the next 48 hours, something serious will happen. And on the other end, this is worth monitoring. We have good options if it changes, and doing nothing for now is a completely reasonable clinical choice. Most people experience every medical recommendation as if it sits at the urgent end of the spectrum, because that is the energy of medicine, right? Medicine defaults to action. prescribing, treating, intervening, referring. And when someone with a medical degree tells you they think you should do something, every cue in that interaction pushes you to yes. But not every recommendation deserves the same urgency. As your parents get older, every intervention, every procedure, every new medication carries a risk benefit calculation that is genuinely different from what it was at 60 or 70. A procedure that is routine for a 50-year-old may carry real risk for an 85-year-old with 3 other conditions. You deserve to understand that calculus before you agree to anything. When you ask what happens if we do nothing, you get the actual stakes. You find out whether this is a situation where time is the enemy or whether watchful waiting is a legitimate and reasonable clinical choice. You find out whether the follow-up procedure could be discussed at the next appointment rather than scheduled tomorrow. And you often find that the spectrum is wider than the visit made it feel. Now, I want to be careful. I am not telling you to second guess your parents' doctors. And I am not telling you that doing nothing is always right. Sometimes the answer is to what happens if we do nothing is genuinely frightening. And in those cases, you absolutely want to know that too. What I am telling you is that you deserve the full picture before you agree to anything. And a good physician will welcome this question because it shows you are engaged and that you are thinking critically about your parents' whole life and that you are the kind of family member who will actually follow through on whatever gets decided. And this question opens one more door. It starts a conversation about what clinicians call goals of care, what your parent actually is trying to achieve with their medical care. More time, better quality of life, the ability to stay at home, freedom from pain, even if that means doing less. Those goals should be shaping every medical decision, and most of the time, no one asks. This question is how you start asking. And what happens when you still don't understand the answer? You ask one of the 3 questions, the doctor answered, and you still do not fully understand. Here's the script. You say, I want to make sure I can explain this accurately to her other doctors and to our family. Can you say that one more time in a different way? You gave the doctor a purpose for repeating themselves that does not involve admitting confusion, right? You are not lost. You are a relay point for important information. That framing almost always produces a better second explanation. And if you are still not clear, use a teach back. You say, let me make sure I have this right. Can I repeat back what I understood and you tell me if I'm missing something? And then you say it back in your own words right there in the room. This is one of the most evidence-based tools in health communication, and a good physician will be relieved, not annoyed, because they would rather fix a misunderstanding in the room than get a call at 11 o'clock at night. And remember, medical language is genuinely a different language. Benign means not cancerous, not harmless. Chronic means ongoing, not severe. Idiopathic, one of my favorites, sounds authoritative and specific. It actually means, we don't know the cause yet. You are allowed to ask what every term means, every single one. Do not let a word you do not understand leave that room without a translation. And remember, physicians at heart, good ones, are educators. We teach, right? And so the hospital question. Hospitals require a specific additional tool because you are no longer dealing with one physician who knows the whole story. You are now dealing with hospitalists who rotate every few days, specialist consultants focus on a single organ system, residents and a different nurse every 12 hours. On any given day, 4 or 5 different people may have written something in your parent's chart with no one holding the complete picture. The single most useful question in that environment is, who is in charge of my mother's care today? Ask it at every shift change. Ask it when a new face walks in. Ask it at morning rounds. Know the attending's name each day and be there when they round or call in. That one habit is the difference between coordinated care and 5 specialists, each optimizing their one organ in isolation. Except you're the one who sees the whole person. Make that visible. So, I want to call this a 10-minute parking lot debrief. The visit is not over when you walk out. Spend 10 minutes in the parking lot before you start the car. Write down the plan while it's still fresh, not from memory tonight. The new medication, the threshold, what you are watching for, when to call. Memory under stress is a terrible note taker. And when you are under more stress in that room than you realized. Then send a 3-sentence summary to your siblings. Saw Dr. Patel today, starting a new blood pressure medication, watching for dizziness, recheck in 6 weeks. If she seems off, call me first. That one habit prevents the 2 most corrosive family dynamics I see. The out-of-the-loop sibling who becomes a critic, and the responsible one who carries the entire medical picture alone until they burn out. And on the drive home, ask your parent, what did you take away from today? You will sometimes be startled by the gap. Your father heard the heart thing is fine when the doctor said the heart thing is stable on medication. Those are different sentences. The drive home is where you close that gap gently while it is still small. Now, how to ask without burning the relationship. I want to spend a few moments on tone because the same 3 questions can open a door or close one depending on how you deliver them. First, announce yourself as a partner at the start. 1 sentence, doctor, we are so grateful to have you in my mom's corner, and I want to make sure we use this time well. That reframes everything that follows as collaboration, not interrogation. Second, ask the question, then stop talking. Families often ask a great question and then immediately fill the pause with 3 more. 1 question, wait for the full answer. The silence is the doctor thinking. Let them think. Third, keep your parent at the center. Direct questions through them when you can. Mom, do you want to ask about the dizziness or do you want me to? Nothing erodes a parent's dignity faster than feeling talked over in their own appointment. And when the doctor starts directing everything to you while your parent sits there being discussed in the third person, gently redirect. Turn your body toward your parent. Mom, what do you think about that? Most clinicians self-correct immediately because the habit is usually unconscious. The visit belongs to your parent. Sometimes you are the one who has to hand it back. And finally, know the difference between advocating and prosecuting. You are not there to catch the doctor in an error. If after multiple visits with respectful questions, you genuinely cannot get traction, the answer is not to fight harder. It's to find a doctor you do not have to fight. You're allowed to do that. It's one of the most loving moves an adult child can make. And I want to tell you what sits behind this episode for me. I have been on every side of this room. I have been the physician dealing with the full problem list and 12 minutes. I have been the consultant called in afterward when the plan went sideways and there was no plan B. And I have been the adult child in the chair against the wall, holding my list, heart pounding, wondering if I was allowed to speak. That last one is the one I want to stay with for a moment. I am a triple board certified psychiatrist. I speak this language fluently. I know what the terms mean. I know how to read a chart. I know how to ask questions and when to push back and when to let something go. And I still catch myself in medical appointments for people I love, nodding along, going with the flow, letting the momentum of the visit carry me forward. Yes, before I have fully processed what I'm agreeing to. Because the pull in that room is real. The efficiency of the visit, the confidence in the physician's voice, the implicit understanding that this is what you do next, the faint pressure of not wanting to be the person who slows things down or questions the event or the expert, right? I feel it with all my training and I still feel it. So when I think about what it is like for you, someone who's also managing your own fear about what this appointment might mean, who maybe took time off work to be there, who has not slept well because you were up worrying about what the doctor might say, and then you walk into that room and everything is moving fast and the language is unfamiliar and your parent is nodding and you don't want to make it harder for them by seeming anxious. I understand why you leave the parking lot typing, I think it went okay. I'll call you later. You were never taught how to be in that room. Nobody was. That is not a personal failure. It is a gap in everything we give families who are doing one of the hardest jobs there is. That is what this episode is for. These 3 questions are the thing I wish someone had handed me the first time I sat in that chair. And now I'm handing them to you. Here is a whole episode in 2 minutes. The medical visit defaults to triage. The family is allowed to steer it. 3 questions are the steering wheel. Question 1, what are we watching for? Gets you the monitoring plan, the specific signs that things are getting better or worse, and what would prompt a call before the next scheduled appointment. Write the answer down on paper in the room in front of the doctor. 2, what is most important to my mother right now? Ask your parent first in front of the physician, then ask the doctor to respond to that answer. This reorders the entire problem list around your parents' actual life and values. It hands the quietest person in the room the floor. Question 3, what happens if we do nothing? That gets you the actual stakes, the natural course of this condition untreated, whether this is a 48-hour urgency or a watchful waiting situation. And it opens the goals of care conversation that shapes every decision going forward. Bring the 1-page brief to every appointment. Medications, what has changed with your dates, your top concern, and 1 sentence about your parents' goals. When you do not understand the answer, say you need to relay it accurately and ask for a different explanation. Then teach it back in your own words. And hospitals ask at every shift change, who is in charge of her care today? And spend 10 minutes in the parking lot. After every visit, write down the plan, send your siblings the 3-sentence summary, and close the gap with your parent on the drive home. You are the only one in the system who sees your parent as a whole person. Now, you have the tools to make that visible in every room you walk into. Comment dictionary, and I will send you my free medical dictionary straight to your DMs. It's 50 of the most common terms in your parents' chart and discharge summaries, explained in plain language, so the medical record stops being a foreign country. Next week on the Aging Parent Playbook, we are staying in care clarity, but going somewhere I have been waiting to take you for a long time. The episode is called The 6 to 18 Month Window You Are Missing. There is a quiet window before almost every caregiving crisis. Most families never see it until it's closed. I am going to give you the 8 signs that you are in it, and I'm going to tell you about the first time I noticed a window in someone I love. If you've ever looked at your parent and thought about something is off, but I can't prove it, yet that episode is especially for you. Until then, take care of your parent and take care of yourself. See you next week.